1 second. I'll just ask.
Yeah. So the screen is visible. Please switch to full screen mode.
Shweta, how to do the full screen?
It must be there at the bottom of the screen, sir.
No, that when I do, I'm getting like this.
Maybe because you need to click on enabling editing first.
Enabling.
Where is that?
It's at the top, sir. Protected view.
1 second. Can you see that the ribbon of the Zoom?
Oh yes, I think I'll share these slides from my end. There's some error. I'll share it from my end, sir.
Okay.
Right? If you can please stop sharing.
Yes, I'll do that. Yeah.
Kiran sir, can you please confirm if the screen is visible?
Yes, it's visible.
Right.
Screen is visible.
Right.
Yeah.
Okay. Kiran sir, can we start the recording, please?
Yeah.
Good afternoon, everyone. ITech India and Manipur SACS welcomes all the participants for today's RDLS session. Today's topic is Welcome Back in Review Clinic for Children and Adolescents Living with HIV. And the speakers are Dr. Ramesh Allam sir from CDC India, Dr. Hemlata ma'am from Manipur SACS, and Dr. Rajeeb sir from ITech India. We welcome you all for today's session and request you to start the session.
Okay, very good afternoon, all the participants of today's webinar on the topic Welcome Back Review Clinic for the Children and Adolescents Living with HIV. We will be taking a 1-hour session on the how to bring back the children and the adolescents living with HIV to the ART center. That is all about today's webinar. And so to start with, I would like to request Dr. Ramesh to kindly start the session. And
yeah, thank you. So today the objective of this session is to ensure that all children who are there on ART in all our 12 centers in Manipur we should review them from this November. By mid of December. All the children who are there on ART should be brought back to the ART center. And when they are brought back, what are those 5 to 6 things that each of the staff at the ART center should be doing, and how to report it back to the PCOE and to Manipur SACS, so that they will be reviewing how better are we providing care to these children. And data should be coming to MSACS regularly, and how the data should be sent will also be discussed. You will also get help from some of the staff of the program assistants of ITech who are currently there in each of your ART centers. They will help you out how to compile this data and share it with SACS. So with next slide now. Yes, as you know, we have almost around 1,700 patients who are on ART, and this is, I'm taking it from all the 3 states of Manipur, Mizoram, and Nagaland combined together. So we know that of all these patients, 20% of these children do not come regularly to our centers. It is because they may be going to school and it is not cost effective for the child and the parents to come. There are several reasons. So we know that about 20 to 30 of our children who are on ART will not be coming to the center regularly. And we also know, because of the children are not coming regularly, the dose of the antiretroviral therapy for these children will depend on their weight. So if the children are not coming to the center, we are not monitoring their weight, and they are getting the same old regimen what they were put on 6 months or 1 year back. So this is leading to subtherapeutic dosing of antiretroviral therapy, leading to an unsuppressed viral load. And this is a criminal part of what we are doing. We are not doing good to the children. We are only trying to just write a prescription and give. We are not saving the life of the child. So for all of us, it's very important to understand how to monitor these children when they are coming back to the ART center in these 2 months. Next slide. Now, while these children have many challenges, for example, there are programmatic and diagnostic challenges. I already told you that we may be not able to diagnose all the children with the opportunistic infections because there are certain challenges. There are socioeconomic challenges in terms of not being able to afford to come to the ART center every month, and normal childhood and adolescent problems as they rapidly grow. And also the taste of the drugs are not so great for children, and primary caregivers may be going to job, and they may be facing some stigma, discrimination, inadequate public transport system for the patients to come to the ART center. So these are all some of the challenges why the child may not be able to come back to the ART centers. Next slide. Now, with all these, what is happening? If the child is not coming and we are not able to have that adherence monitoring, we are seeing that 13% of our children are not virally suppressed. This is a very big number. And you know that we do not have many options for second line for children. As for adults, yes, we have at least some 3 to 4 different regimens that we can give. But for a child, we do not have many options if they are failing therapy and coming back to the second line. Hence, it becomes very important as and when the child is coming, the proxy visit, specifically when the child is not coming and because of poor adherence, there is inadequate monitoring, suboptimal therapy is what we are giving, and eventually it will lead to treatment failure. And very early, if the child is getting treatment failure, we do not have any options. So this is all the life-saving thing that we are doing, and we need to be very mindful of what we are doing. Next slide. Now, you are seeing in this slide, the campaign is from November, that is starting from today. until December 15, all the ART staff, specifically the counselors in your centers, will have to make calls to these children and their parents so that they come back to the clinic within this 1 month time. And when they come back to this clinic, what we are going to do is we are going to provide in-person clinical contact with this ART during these 2 months. Whenever we want to see the child physically. The medical officer should be seeing this child physically. And if they have just come in the last 15 days or so, that's okay. But as much as possible, we will want to touch the child, see the child, examine the child, take the viral load, take the CD4 count, whatever is possible in the next visit. And the second thing what we are going to do is assess for the appropriate dose and transitioning of most patients to the appropriate recommended regimen. For example, if the patient is more than 10 years of age and still they are on some NNRTI-based regimen or a PA-based regimen, we have to substitute the child for a DTG-based regimen. Or we can also give an option of, we give abacavir, lamivudine, and dolutegravir to these patients. And if dolutegravir single is not available, we will see what best to offer. But we need to see the weight and the dose that is required. And then we also have to have the adherence counseling for viral load coverage. You all have to ensure that every child who is going to come in the next 2 months, and definitely all the children should be meeting you all in person. So whenever they come up, we need to ensure what was their last viral load, when did they get it, and refer them to a viral load. And then if somebody has a higher viral load, we do an enhanced adherence counseling and fast track all these children for ESACS and provide appropriate tools to monitor adherence and weight. The important thing what we are going to do is, once the children are coming to us in this next 1.5 months time, the parents will be accompanying them. So we need to give in the green book of the child, next time if the parents or the guardian are coming, they need to note the weight of the child while coming back to the ART center for the next visit. And also to be able to tell you whether the child is having any other symptoms or signs, so that we will be able to make some appropriate decision on them. Next slide. So there are certain things that every ART center should be following, these 6 steps. Number 1 is you will have to get a list of all these children who are on ART, make a line list of them, and all these lists should be with the ART center. And once you compile all the list, SACS will be sending you an email to provide them the list of all these children, their status on viral load, when they came back here, what was the regimen that was changed, and what was the previous regimen the child was on. So this information is very important for SACS to plan their drug schedules and also to plan the logistics for the drugs that are required at these ART centers, the regimen of the drugs required for forecasting of their drug. So the first thing is we need to have a list of all the children, and block-wise data we need to have from which block the child is coming. Suppose the children, you have tried to contact their family members and they have not come back by the end of December, by the end of November, you need to give that list for follow-up, and a home visit should be made, and make use of all the ORWs present. Don't just give it to Vihan. You can give to Vihan, you can give to the OVC project staff from JHU or Accelerate project, so that they are responsible to bring those families and children back to the ART centers. Irrespective of the children getting drugs from any site, any differentiated service delivery model, they should be brought back now to the ART center physically. And if there are certain institutions or orphanages where most of the children are, I request the medical officer if they can make one visit to these orphanages, so that you can see all of them there instead of all the children coming to the ART center. So these could be some leeway that we could provide to the children so that we do not miss them, number one. Number two, we are seeing them physically. And you need to sensitize all your ART staff within this, with who all are listening to this webinar, and you should be following it. And whenever the child comes back, you need to check the weight, you need to give a counseling. The prescription needs to be rewritten by the medical officer there, and the PCOE will be monitoring this activity from here. And all children with any referrals, please refer them to the PCOE if you have any other challenges. And the experts are here to guide you. So the very key important thing from every center, I want you all to follow this 1 to 6 components with spirit at your centers, and SACS and PCOE will be together helping you out and monitoring. By the end of one month or 45 days, we need to have every child coming back to the ART center. And there's no negotiation on this. This should happen, and this has to happen, wherein we want to monitor the drugs of them, because there are high unsuppressed patients among children. This should not be happening. And we want to transition as many patients as possible to dolutegravir-based regimens or any other effective regimen instead of having that subtherapeutic doses. Next slide. Now, I have already told you what should be doing as part of the desk review. All the counselors and data managers in the center should be doing this. You have to see what is the regimen the patient is giving, what is the gender the patient is, what is the weight as per the age, what is the MMD status, whether the patient or the child is getting a multi-month dispensation, when is the viral load due. All these things you will be putting it ready in that line list of patients that you will be preparing, which needs to be submitted to SACS at the end of at the end of November and mid of December. Next slide. And then in order to ensure that every child is called back or a home visits are done, we need to do a block-wise tracing of all the segregation of lists. And then you develop and then we ensure that the guidance is given from all the SACS, like how Manipur SACS is able to now take the leadership here. The PCOE will also be doing such webinars for Mizoram and Nagaland, because they are the nodal centers for both these states. And the calling activity will be taken up by the outreach staff present, the counselors present at the ART centers. If there needs to be a home visit, yes, the outreach staff will be going to bring back the children to ART centers. And we need to ensure that the TB preventive therapy, the cotrimoxazole, ATT, ART regimen, CD4 and viral load monitoring are done adequately, and they should be more recent. And any patient with a CD4 count less than 200 for the children who are aged more than 5 years should be provided with cotrimoxazole, with less than 350 should be provided with cotrimoxazole prophylaxis. Do a good 4-symptom screening, and if the child is 4-symptom negative, please start IPT in these children. This is your opportunity to saturate all our children on IPT. Next slide. Now, this is the opportunity again. I am retrying, and SACS and PCOE are putting in all their efforts to ensure that all the children, you understand if there are any adherence barriers and what are those that could be able to prevent them from becoming an LFU or not taking drugs regularly. Please ask every child whether they are taking the drugs every day, they are taking in the morning or evening, whatever the dosage the patient, whatever the type of BD dose or OD dose the child is on. We need to ask the child first. Don't ask the caretakers. First ask the child, when are you taking the tablets? How many tablets are you taking? We need to make some effort. And you have to know my pain why I'm telling all these, because 10 to 15% of our children are not virally suppressed. That means they are not taking drugs regularly. Don't think they are taking drugs regularly. There are challenges. We are here to support them, help them out. Next slide. Now, we need to segregate these children into three: patients who are alive on ART, patients who are lost to follow-up, and patients who are in some orphanages or anything, for you to understand. Because if patients who are in differentiated service delivery models, like in an orphanage or in an institution, we can talk to the institution head, get all those children on 1 day or 2 days, we give them. And if they are lost to follow-up, we need to now start tracking and tracing these patients, and they needs to be prioritized, and the list should be given to the VHAN or any other staff. And on Saturday, what we are going to do along with SACS is that we are going to prioritize some blocks for LFU tracking and tracing. And there we will have our ORWs fixed for each block in each district. So that also SACS is going to take up and support ART centers. Next slide. Now, there are two groups of patients. There are some patients or children who are alive on ART, or they would have been lost to follow-up, or they are in Miss 1, Miss 2, Miss 3 category. So suppose a child is alive on ART, you call them up 1 day prior, okay, and ask them to come to the ART center and provide the package of services what we have just discussed, like those 5 things what you should be doing. You assess the weight, you see the dose, you see whether the child is in advanced disease, you give IPT, you give, so all that should be followed. Suppose the child did not come back even after you call, you then, the program assistant will again call them 2 or 3 times. And if they come to the ART center, that's okay. If not, the home visit should be done by the respective staff who will be notified in the coming 2 days, who will be taking care of this block, and then the list should go to them. Irrespective of any type of ORW within the National AIDS Control Program, we will be dedicating them for that block for tracking and tracing. So that will be done through a home visit. Suppose it is a loss to follow-up case, the counselors will do a calling activity. Like the current guidelines, the counselor will be calling at least 3 days on 3 different times on 3 days. And if the patient, if you are not able to reach them out, then you give for the home visit, and then the outcomes will be detailed out. So this is what we should be doing. The counselors, the data manager, and the medical officer should be working as a team in order to ensure that Manipur has all the children who will be safe, who will not die soon, and whom you will be helping out. So this should be the motive of this, not just think that, oh, SACS is telling us to do, we need to do. Please put the child at the center, then I think things will move from your end. Next slide. Now, for children who are in institutional homes, yes, we can also ensure that we can go to that site and ensure a physical clinical examination by the medical officer, or they can be given some 2 or 3 days subsequently, or based on the institution's will to come and the children available, we can give some timing to them so that all the children are coming back once. And then the same phenomenon should be repeating every 6 months, so that the child is being physically touched every 6 months is important from the system point of view. Next slide. Yeah, this is a slide what I just told, that you need to call a patient or the family member. If you are able to reach it, you ask them to come on some day, and they will be somewhere, you will have these outcomes. You will come to know either the child has expired, or the child has opted out, or child is willing to come, they don't come. And then you will do attempt to call 2. In the attempt to call 2, you should not do on the same day, do it on the next day in a different time. And then you try to see whether if they are not coming, do a 3rd call again. So based on what is your outcome, you need to fill all these in that Excel sheet that you are making it. And yes, SACS will be circulating you that Excel sheet today or by tomorrow to all the centers, where you need to keep updating all these things. So next slide. Home visit also same thing. Next slide. All these you know. Now, whenever a child or an adolescent is coming to an ART center, you have to do the 4 symptom screening. They will have to go to the counselor, look for proxy visits or not. You again see the age of the patient, age appropriate disclosure. The staff nurse, it's important to confirm the current age, measure the weight and height, monitor the vitals, assess for advanced disease. All this is very important, and the Pediatric Center of Excellence will be able to help you out if you have any doubts in this flow chart. Next slide. Now, what all I have told you, just a recap of everything is, we need to have the regimens that are age appropriate, weight appropriate, infant ARV prophylaxis is important, and counseling of CLHIV. Let's see and recap on all these 3 to 4 issues now. Next slide. Now, as you know, these are the guidelines. If you have seen the newer technical guidelines that are available, and if you all have attended, this will be a repetition, but who had not attended earlier, this will be your another opportunity to listen to. If you are getting a child who is less than 6 years of age and body weight is less than 20, the recommended regimen is abacavir, lamivudine, and lopinavir-ritonavir. And if your age is between 6 to 10 and your weight is 20 to 30, more than 20 kgs, then you can be put on dolutegravir single dose along with the abacavir and lamivudine. Then if the age is more than 10 and weight is greater than 30, for all practical purposes, consider all these children as adult doses and continue. This is very, very, very important as part of the transition, because you know currently there are a bit of shortcomings in the stocks for some of the drugs. So this will become a very important thing. Please check the weight. If the child's weight is greater than 30, just put them on TLD with an age greater than 10 years. Please reassess the age. Ask them clearly, because we do not want the child to get deprived of the best regimen available. So this is another good opportunity for us to transition as many of our patients to the best available regimen. Next slide. So TDF, that's what I told, is advised to children with age more than 10 years and weight more than. That is, tenofovir is advised only for children more than 10 years. That is the reason we are not giving TLD to patients who are between 5 to 10 years and less more than 20 years. So this is one important thing, because tenofovir we are not giving them. We are just continuing them on abacavir and lamivudine. And DTG 50 milligrams is advised with 6 years and weight more than 20 kgs. This we are giving with AL, abacavir and lamivudine. Next slide. So these are all the weight and what is happening to these children. I will share all these slides, and they are available in the current guidelines. So I will not be talking more about these things. Next slide. Next slide. Right. So, and this time in our guidelines, we have given the pediatric dosing chart. I want all the ART centers to print one sheet of this and put it on the medical officers' desks, so that we don't know, we cannot remember the dose of every drug. So it is important for us to have this right on the table where we are prescribing, so that whenever a child comes, we could refer the weight and see whether it is weight and age appropriate or not. Next slide. Next slide. Right. Now, once the child is coming to the center, you're looking at the weight, you're looking at the age, you are making an age and weight appropriate decision on the therapy. You are seeing whether the child is eligible for either AL lopinavir-ritonavir, or it is abacavir, lamivudine, and dolutegravir, or it is tenofovir, lamivudine, and dolutegravir. So these are the 3 decisions that you're trying to make. Once you make the decision, it is important again to enforce and reinforce on adherence. So child-related factors, usually because they depend on adults, so we need to tell them that the parents or their caregiver knows that when to give the drugs, and they should be going and actively asking their caregiver for drugs every day. And the child also should be informed on how to remember taking these drugs so that they go back to their caregiver and ask them. Emotional issues, using medicines to manipulate others. So all these are some of the child-related factors. And caregiver, yes, misconceptions on treatment, what are the health benefits? They need to monitor their children or their guardians every month whenever they come back to the ART center. Next slide. Now, adherence fatigue in children. Usually children may get tired of taking medicines. So this is one important thing that we need to say, again, reinforce through the guardians and the caretakers that this is lifelong, they need to take these, and this is going to make them healthy. So these are all the messaging that we need to do at least every quarter to the caregiver of the children, and to the children at least every contact they make to the ART center. Next slide. Yes. Now in the guidelines, we have included this age-appropriate counseling messages about HIV infection. So I don't know how many counselors have seen this, but this again, if the child is between 3 to 6 years, the messages you are going to give is that you are not well. If you want to play, you should be well, and for that you need to take medicine. So these are some of the examples that the guidelines have given, and I urge all the counselors, medical officers to please go and review the technical guidelines that have been provided by NACO, specifically the chapter on there is a section related to children, and I think it is section number 3, where you can get everything of the counseling tools. And really, NACO had made tremendous efforts in drafting these guidelines, and the PCOE is part of the drafting of these guidelines. So there is no other place that you should go searching of all these except those guidelines. Next slide. Now, how do you prepare the parents or the caregivers, which is very important? Next slide. Yeah. So we also see some of the adolescents coming to our center, and they should be mainly counseled on knowing their status, accepting their status. These are very important. Next slide. Next. Right. Other important one while we start preparing the patients or caregivers is that they need to decide how, when, and by whom disclosure will be implemented. This again is a very big phenomenon of disclosure, and we have given a very detailed explanation in the current guidelines on where you get the information of this. Next slide. Now, adolescent care is an important thing because there are certain children who have got this infection vertically, and there are certain children who have been exposed after birth and then they had got HIV. So we can categorize them into vertically infected, and then you also say horizontally infected adults. So in the guidelines, we have given you a good tabular form. Whenever you are going to get adolescents while you are going to have this welcome back clinic to the child and adolescents, you will have to have your counseling focused. If an adolescent that is who is aged more than 9 years is coming to you, you have to look into whether the child had this infection from the mother or it is a exposure that has occurred later. And based on that, you need to start looking at how do you counsel, and what is that the child requires or that adolescent requires is important. Now, this is all abstract what I tell you, but when you see the child or the adolescent in front of you, try to categorize them as a vertical or a horizontal, trying to know the factors from how they got exposed. If it is not a vertical transmission, will help abundantly for the adolescent to be on ART. Usually, this is the age group where you see a lot of patients who are not coming to the ART center regularly. Next slide. And the needs are different because there are care and treatment needs, there is a gender need, there is a life skill communications that they want. So these are all the things we need to take help. And if you require help from PCOE, please call them up, fix some time for the child, because most of your centers may not be having medical officers. So PCOE with their counselors, and there is also a nutritional support counselor here at the Pediatric Center of Excellence whom you can access to and talk about children who have some malnutrition or nutrition related problems. Next slide. So using these 5 A's in adolescent, that is to assess, advise, agree, assist, and arrange. Now, what is that you have to assess them is, if there are adults who are young pregnant women, if they are coming and they are in an adolescent age, that again is a very great challenge both for the mother and the child. Next slide. So this assessment is required. And then once we start assessment, next slide, we need to also look at what is that advice we are giving for the treatment plan. For example, we need to give them an option of how do you reduce the risk of transmission of HIV if that adolescent is already positive for the child. How do you prevent that? So getting a viral load done, do it in your last trimester, and then you put them on either a mono or a dual prophylaxis based on the risk group of that particular young adolescent mother. So these are some of the things that we need to see. Next slide. Then assist. Whenever we say assist, we need to have a written or a pictorial summary of that plan. You put yourself in the shoe of these adolescents who may be coming in your next 1.5 months and try to see what are those needs that you want and how you want to manage that patient, both psychologically, clinically, and then you provide medication to them. Next slide. And as you see, this disclosure is a very important thing, and it is not a one-time thing that you need to do. It has to be done in a progressive manner with 2 or 3 sittings with that adolescent, and try to ensure that they are not surprised or get a harm out of knowing their status. Next slide. Now, coming to the last 2 slides, we need to ensure that who are the children visiting to us, and this will be prepared with only if you have your line list that SACS will be sharing with you today, tomorrow. You start filling it up. The data you can see for yourself, all these M&D plan. It is not for the center to do it, but the center should be filling up that Excel sheet. Next slide. What we will be sharing, and then provide the information back to SACS so that they do all this monitoring and evaluation, doing this denominator, numerator, what is the data source and all. Next slide. Next slide, Sweta.
Yeah, sorry, sir.
No problem. So this is how the what you are seeing on your screen, this is how the Excel sheet looks. So that same template you need to keep filling, and SACS will be asking you some blockwise information. What is the drug name the patient is currently on, and after the visit, what was that regimen? So it is going to, you need to take support from the program assistant or all other centers except RIMS, GENIMS. You can all do it individually because you do not have children. More than 20 children you do not have in your centers. So it is just a one-day job to complete this. And when the child comes back, fill the other half of the Excel sheet. Next slide. Yeah, next slide. So all these will be shared to you. Are there any doubts that you have? With this, I complete my presentation, but there is somebody having some doubt. Please share the template of the meeting for further review. I mean, if you want the presentation, that I will share it. But what is the template? If it is the line list, that will come to you, Moses, from SACS.
So can we give mic access to all now?
Yes, please.
Yeah. Kiran, sir?
Given, ma'am.
Thank you.
So everybody can shout now what all you're thinking.
If participants have any questions, they can unmute themselves. They can unmute their mic or even type in the chat box.
Okay, now I have almost around 1, 2, 3, 4, 5, 1, 2, 3, 4, 5. Almost 20 participants I have leaving some of them. I want all 20 participants to give responses in the chat box. Okay. First question. How many children, approximate number of children you have in each of your centers? You put the name of your center and write the number beside that. Start now. 20, all your 12 centers numbers I want. Approximate numbers. Let it not be exact. Approximate number of children in your centers. Nobody's typing. Everybody left your laptops there and all went for lunch. Huh? Nobody is still. Hey, very good, Tamingla. 3. So this is going to be your attendance also. Huh? Yes. RIMS 33. What about Chorachandpur? CC4 83. Then Ukrul. Jenims adults, they don't have children. Vishnupur 5. Yeah, Vikram, tell me. Others are absent, huh?
Center award pa.
Sir is there.
Last note.
Can sir talk? I'll tell him to. Okay, so as you start, as you keep writing your total number of children, we have with us Professor Kameshwar Rao Singh sir, who was here all through this presentation, and we are grateful that sir and his team are able to make this presentation for you all, and they have come forward in a way that they will be able to clear most of your doubts that you have. And this 1.5 month is going to be a very good enriching period where PCOE will be trying to help you all. So yeah, we will send the presentation. Just give another 2 minutes for us. Dr. Hemlata will be sharing the presentation to everybody. We have not yet concluded. Just wait for another 1 minute.
Participants are requested to kindly be with us. So we'll join soon.